Assalamu alaikum students. Today we will discuss the third part of cardiac arrhythmias, in which we will continue our topic on heart blocks. As you have studied on uh, your sinoatrial block and then AV block, and AV block is of two types, incomplete and complete, and now this is the complete AV block. And you have also seen in the previous lecture on cardiac arrhythmias part 2 that incomplete AV block is further divided into first degree and second degree is further divided into Mobis type 1 and Mobis type 2. And now it is the continuation, that is third degree heart block. And this is the complete, as the name indicates. So the conduction of impulses from atria to ventricle is completely blocked. And ventricles start their own rhythm at a slower rate, 40 beats per minute, rhythmically signals generated by AV node. As you know, the conduction speed of ventricles, your AV node is 40 beats per minute. So the ventricles start their own rhythm, and they become independent from the effect of SA node. You can see in the third point, atria beat independently with SA nodal rhythm, and ventricles beat independently, and there is no connection between atria and ventricle. So there is no relation between the rhythm of P wave and that of QRS T complex, because the ventricles have escaped from the control by the atria, and they are beating at their own natural rate. So the very important point is that the ventricles have escaped from the control of atria. So there is no relation between P wave and QRS T complex, as the P wave indicates atrial depolarization and QRS T complex indicates ventricular depolarization and repolarization. So there is no relationship between P and the QRS T complex, as you have seen that ventricles have escaped from the control by the atria, and they are beating at their own natural rate, because the conduction pathway between the atria and the ventricle is blocked, and this block is complete block. So the ventricle have escaped from the control by the atria. And you also see in the ECG that P waves are dissociated from QRS complex. You can see here P wave, P wave, P wave, P wave, and then QRS. So there is no association or no relationship between P and QRS complex. As you can see here that after each P wave there should be a QRS complex, but you see in this picture it doesn't happen, and P waves are dissociated from QRS complex. And regarding a third degree heart block, there is a disease, there is a problem that is called Stokes-Adams syndrome, ventricular escape. AV conduction ceases, borderline ischemia of the conduction system. The AV conduction, the conduction through AV node is stopped because of ischemia of the AV pathway, as you have studied in the previous lecture. What can happen to AV conduction pathway? There is either ischemia, there is either inflammation, or there is either a scar tissue. So the AV conduction ceases. The duration of block may be a few seconds, a few minutes, a few hours, or even weeks or longer before conduction returns. So the duration of block varies from seconds to weeks, and ventricles often do not start their own beating until after a delay of 5 to 30 seconds due to overdrive suppression. So the ventricles do not recover and it takes a delay of 5 to 30 seconds because of overdrive suppression, because of excessive suppression on the ventricles. Because when the ventricles escape from the effect of atria, they first suppress and then they regain their conduction speed, and they may suppress for 5 to 30 seconds. That is very important point, that when the ventricles escape from the effect of atria, they first go under overdrive suppression, that excessive suppression, and then they recover. And it may take 5 to 30 seconds. After a few seconds, some part in the Purkinje system beyond the block, usually in the distal part of AV node, beyond the block point in the node or in the AV bundle, begins discharging rhythmically at a rate of 15 to 40 times per minute and acting as a pacemaker of the ventricle. This is called ventricular escape. So the ventricle get its escape after a few seconds when the Purkinje system beyond the block works. And it works by discharging rhythmically at a rate of 15 to 40 times per minute. So the ventricles escape from overdrive suppression. That is very important. Firstly overdrive suppression, then ventricular escape, and it takes 5 to 30 seconds. Brain cannot remain active for more than 4 to 7 seconds without blood supply. Most patients faint a few seconds after complete block occurs because the heart does not pump any blood until the ventricles escape. So the blood remains without blood supply for 4 to 7 seconds. And after escape, however, the slowly beating ventricles usually pump enough blood to allow rapid recovery from the faint and then to sustain the person. And then when the ventricles escape, even they beat slowly, but they provide enough blood to the brain to sustain the person's life. These periodic fainting spells are known as Stokes-Adams syndrome. So these fainting spells, which occur from time to time, these are called collectively as Stokes-Adams syndrome. So you should know, firstly, as the block occurs, there is overdrive suppression of ventricles, and then after 5 to 30 seconds, there occurs ventricular escape, which occurs due to the conduction of or due to the working of Purkinje system beyond the block, which makes the heart to beat at a rate of 15 to 40 times per minute. And then uh, brain remains without blood supply for 4 to 7 seconds, and when the escape occurs, the there is a regaining of blood to the brain, and these periodic spells, fainting spells, are called as Stokes-Adams syndrome. Occasionally, the interval of ventricular standstill at the onset of complete block is so long that it becomes detrimental to the patient's health or even cause death. So if this take time, if ventricular escape take time and the patient remain in overdrive suppression of the ventricles, that might be detrimental to patient health and cause death. Consequently, most of these patients are provided with an artificial pacemaker, a small battery operated electrical stimulator planted beneath the skin with electrodes usually connected to the right ventricle. So an artificial pacemaker, a small battery operated electrical stimulator is implanted beneath the skin, and its electrodes are connected with the right ventricle so that ventricles doesn't go overdrive suppression, and the pacemaker provides continued rhythmical impulses that take control of ventricles. So the overdrive suppression of the ventricles is prevented, and thus the Stokes-Adams syndrome can be prevented. And because if this overdrive suppression or this Stokes-Adams syndrome will remain for a longer period, it may cause problems with the brain, and it may be detrimental to the brain. So it may cause paralysis. If it affects the major portion of the brain, it may cause paralysis, because if recovery doesn't occur, then it will lead to the paralysis. Adams Stokes-Adams syndrome is you can see here normal ECG, but here is bradycardia slowing down. When there is overdrive suppression, then there is a slowdown of the heart rate. The heart rate goes slow down. You can see in the picture here SA node, here AV node, and you can see here there is no connection between SA node and AV node. Current flows from here, bundle of his, then Purkinje fibers. Here, there is all okay here beyond the AV node, but you can see here between SA node and AV node there is no connection. So if this occurs, patient may go into fainting or syncope. Syncope or fainting is the same thing. This is senseless. Person goes senseless for 5 to 30 seconds, and then there is recovery by the ventricular escape. So there are main 2 points in Stokes-Adams syndrome. One is overdrive suppression, and other is ventricular escape. So be focus on these, and in your complete AV block, you can see here there is no connection. Atria beats on its own, and ventricle beats on its own, and there is no relationship between P wave and QRST complex. You can see here P waves occur, they are on, and QRS they are on, because after every P wave there should be QRS, but you can see here this doesn't happen here. Okay, so in the 3 lectures on cardiac arrhythmias. Up to now, we have firstly discussed the sinus rhythm, tachycardia, bradycardia, and in the second lecture we discuss sinoatrial block and incomplete AV block, and in the third lecture of cardiac arrhythmia, so we discuss about the third degree heart block and Stokes-Adams syndrome. And the lectures on cardiac arrhythmias continue. We will take almost 2 lectures more to complete this topic.